Testing audio. Have people been able to hear me coughing and clearing my throat? Sorry, Amy. I'll actually figure out how to mute my microphone. And Amy, you might spy a little gift that you provided me in of my situation here. All right, thank you, Elizabeth, for turning it back over. I do realize that people are still kind of coming in, but I recognize that we have our
1 o'clock colleagues as well. So with that being said, I will go ahead and get started. And I see it's recording, so I think we're good to go. Is that right, Elizabeth? All right. So hi, everybody. My name is John Wallace. I work at the North Carolina Institute for Public Health. We're at the UNC Gilling School of Global Public Health. And today to present some results of our COVID survey that we sent out to the Chatham County folks we've been working with for a while. And I'll get into the ins and outs of this. But first, I want to thank my colleagues who helped with this. First and foremost, Michael Zellick from Chatham County, also NCPHA president. We are always grateful for their support and participation. And then other colleagues, Allison Singer, Matthew Simone, and Jesse Edwards, who all played a contributory role in these. So I also want to thank the Chatham for their overall support, and that would also go with Leighton Long as well. And fingers crossed for slides. Great. So I'm not sure how many folks are familiar with this idea of the Chatham County Community Cohort. And this is something that we've been working on with in collaboration with the Chatham County Health Department for the last 3 years or so. So in 2018 and kind of the years prior, came up with this idea of, for their community health assessment, for their primary data collection, instead of mobilizing every 3 to 4 years for primary data collection, why not try and set up something where we can follow folks long term, over time, and engage more stakeholders, engage the community a little bit more, and really think about being able to measure some of the gaps in community data that we know exist and that we're able to resolve through community, through primary data collection and community opinion surveys. So the purpose of the community cohort was really to systematically select a group of folks to follow over time, and use their information, their feedback, policy level changes, identify health disparities within the county and various conditions, and help with strategic planning. So they came to us, the Institute for Public Health, with a need for a fairly rigorously sampled population. We did so using our typical methodology, which is endorsed by CDC and the World Health Organization, to select a cohort of folks based on their kind of location of residence. And in doing so, we also stratified by levels. So we kind of broke the county population into 3 stratifications of lowest income, middle income, and upper income, and selected respondents from within those tertiles, within those areas, for our survey, and certified cluster-based sampling design. And that's kind of where I want to leave it for this. We have presented these methods already at NCPHA, maybe 2019 or 2018. But on the map you see here, these are kind of the red areas are the locations that we selected for the community cohort in 2018, and we continue to follow up with those folks. So in 2018, we had 339 folks enrolled for continuous follow-up over time. And here we are 3 years later, or 3 surveys later, 2 years later, we're down to 311. So we've had some attrition over time, but really that's pretty good. We've only lost 28, and those 28 folks, some unfortunately have passed away, some have moved out of the county, and so we no longer consider them Chatham County residents. But overall, we have a very solid base of folks who are willing and able and reliably respond to the community health opinion survey questions that come out once a year. And so it's been a really successful collaboration with the Chatham County Health Department, and it's been a very useful cohort for the county as well. When we initially selected and enrolled our cohort, there was a lot of effort to, and as I mentioned, that we stratified the enrollment by tertiles, so we had a pretty equal distribution. But really, we always want to make sure when we're selecting populations that we have a representative. The best way to do that is to look at the demographics. of the folks that you're able to select. And those demographics generally do align with the county demographics. So here in this table, I've highlighted some of the few based on the 2018 numbers that we have, and then compared that to the 2014 to 2018 American Community Survey data. And this is the most recent. And you can see that we have a pretty good representation, and it looks like you can see my mouse, which is good. We have a pretty good representation. We actually have oversampled from some of the harder to reach communities. So African American, Black populations, and Hispanic individuals, we have those populations that sometimes are harder or more reluctant to participate in surveys. We've been able to reach out to those, and we have them enrolled and engaged within our survey, which is always good to see. And if you look down at the economic tertiles, so we have tertiles 1, 2, and household incomes, it's a pretty even split. And that's what we wanted. We did that by design such that we have approximately equal representation from divisions of median household income, so that low, middle, and highest. And again, you might look at these numbers. The highest income category is kind of cut point at 58,000 for a family, and that high point there is 109,000, but that's really the average of the census block that they live in. We know that household incomes can be much higher. And then on the opposite end, we know that family incomes can be much lower than 21,000. So when you see those bounds, those are averages. And then so we actually asked these folks in 2018 what their household income was. And so you see a little bit more of the distribution of how they're more folks in those upper income categories. But then we do have a really good sampling from folks living with less than $20,000 for their household income. And it's also important to point out how we in-person sampling, but we also were able to set up some web URLs and collect individuals and their survey response. Ultimately, you can see from these top responses here, we enrolled about 82% of our cohort through in-person methods, 12% using the web, and then 6% of folks mailed their surveys back to us. And this again was just the initial recruitment. And so since then, we've obtained contact information from those folks, and so we can follow them up using their preferred method of contact. A lot of times that's email. We also have phone, we have mail, and we can also do in-person. So I wanted to talk briefly about the practical benefits of using a cohort like this. And this is kind of leading us then to how we use it for COVID-19. So it essentially, once we did the legwork for enrolling these folks, it was a large investment. The folks in Chatham County who are probably on this call can certainly attest to the legwork that goes into it. But once we were able to enroll those folks, then we basically have a pre-enrolled representative sample of Chatham households and residents. And so this can then reach back out to those folks annually. Initially, the proposal was to do it up to twice a year. It's turned out that we've done this annually. So we've had surveys in 2018, 2019, and now in 2020. But it allows all other stakeholders to really think through and be able to address those gaps in data. And so if they want information about community issues, about impacts of some of their interventions, they're able to reach out to this cohort and obtain some of that. And on the sampling, we've allowed for a very reliable data source, and we've collected a very reliable and robust data source for Chatham County data. And so it's addressing a lot of those gaps, and it also to follow some of the metrics over time. So the general health and well-being type questions we're tracking over time in addition to some others. And lastly, again, it's a readily accessible cohort or group of folks that we can reach out to. And so this has been extremely helpful in emergency response. And so if you remember in 2018 in the fall, those hurricanes that came through, we were able to mobilize a cohort and do kind of a 5-month follow-up after the hurricanes to see what the hurricane preparedness needs were, so that we can inform, and some of the emergency communication, so that we could then inform operations moving forward based on that. And then ultimately this year, this became a critical feature for being able to do some COVID-19 surveying, surveillance type work, and DPH approaches for that. And that's what I'll get into now. Aaron Fleischauer and Zach Moore from the Division of Public Health Communicable Disease section contacted us because they knew about this cohort and knew that we have this representative sample, and from that we could identify kind of population-based data that at the beginning of COVID was very difficult to come by, and frankly still kind of is. This is that local data, not only for the prevalence, but also just community impacts and community perspectives that are really hard to capture. And when you heard a lot about the initial COVID, people were doing convenience samples, and we know that those are going to be highly biased. And so this gave us the ability to do to obtain some of those same questions and those same data, but from a robustly sampled population that's representative of the county. And this was also part one of a larger aim to do seroprevalence testing as well. So swabs and serum collections are ongoing now in the county. And we used the cohort initially to recruit. So phase one aims, we wanted to look at the population level prevalence of COVID-19, both diagnoses and symptoms. We wanted to enroll for that follow-up specimen collection and then assess those community perspectives. And so in terms of our methods, we had the survey open for about 6 weeks. So May 1st was when we started our first contact. So we mailed out postcards to everyone saying, hey, here's our survey yet again. Welcome back. And we were able to give them the web URL with that, and we started collecting responses immediately. It really just took us about 3 to 4 weeks to mobilize. And if you think the response to COVID really started ramping up in April, we were just a month behind that. So it was very, very timely. We mailed out our survey packet that had a hard copy of the survey on May 8th, and we started phone calls for those who had not yet responded on the 20th and closed the survey on June 10th. We did make a cognizant decision to not do in-person surveying for obvious reasons, for protecting the health of the folks who would be out in the field and of our cohort members. And we'll talk about those effects in a bit. And as I present these results, I do want to also caveat these with kind of the context in which this study was collected, because we started in May, ended in June, and so much has happened since then. If you remember back in May, we were all pretty okay with being at home and social distancing. And then as the days and weeks and months wore on, people got tired of it. So we fully acknowledge that some of these opinions that we collected could have changed. But again, this was a kind of real-time ability to collect opinions from the residents of Chatham County at that point in time, which helped inform some of their health department operations. So among the folks who took our survey, the COVID survey, we had 186 out of our 313 cohort participants. And of those 313, we lost 2 more to follow up. One person passed away and one person had moved out of the county. Overwhelming number of responses were through our web URL collector. Again, that's because we had people's emails. We were encouraging them to collect it on the web because we were not doing in-person surveying. And as I'm alluding to, we'll see the effects of that. 17% of the folks mailed their surveys back, and we were able to contact about 4% via phone. And I'll point out that the phone responses sometimes they are resource heavy at times to make multiple calls and track people down. But this was one of the primary ways to reach the Hispanic Latinx population, because they recognize the folks who are calling from the health department, and there are good relationships there. So it's another important aspect to supplement the web URL collectors, because we know there are issues with those. So in terms of the demographics of the folks that responded to our survey, in general, they were more wealthy and they were older than our full cohort of 313. So scanning through some of these, you can look at this tertile 3, the highest income stratification. About 45%, 44% of our responses came from those. In terms of race, 81% white, Hispanic Latinx ethnicity, again, because of the phone calls, we got about a 90-10 split, and that's pretty close to the county demographics. And I'll point out that race is about the same as well to the county demographics. Household income, again, we were a little bit higher in the income ranges than we had anticipated, but again, mainly web URLs. And then with education, we had a really high proportion of folks with bachelor's degrees and master's level degrees. And that's because, again, this is typically basically sampling a more wealthy population.
About 4 minutes, John.
Okay, thanks. All right, so I'll go through the prevalence and symptoms real quick. Really, very few had symptoms of COVID or major symptoms of COVID, sorry. So only 6% had a fever, but then many people had a headache and dry cough and things like that. And those symptoms range from about 2 to 24 days. The population prevalence that we identified was between 0 and 2%. Really, that's coming from one individual who was told they had COVID but couldn't get tested. Again, think back to May and how testing was a little bit more limited. So community perspectives since March 1, in those 60 days between when we responded to when folks responded to our survey, we found that about a quarter had exercised less than usual. More people were working from home than more than usual, and about 11% had lost business or income. And that's, again, just a quantification of a lot of the things that we've been hearing in the news. And we had a lot of people say that COVID-19 was a substantial or serious threat to their household finances. Again, something that we know, but we have the quantifiable data to back. About a third were essential workers, but then more positive things. So at this time, more than 90% were following those 3 W's of washing hands, maintaining social distancing, wearing a mask. A lot of folks, the majority, were avoiding contact with individuals outside of their household, and most all thought it was very important or somewhat important to keep a distance from others. So we saw a lot of good adherence to social or to public health recommendations. And so the county used that, posted on their website. And the data reinforced, again, adherence to those public health recommendations. And the one thing that I do want to spend a little bit more time on, I know we're wrapping up, is the fact that we had a 60% response rate. And through our population-based sampling, we know that there was a chunk, there were 40% of the people in our cohort who didn't respond. So the natural question is, who are those people and who did we miss? So using this cohort, again, allows us to do that. And this is kind of a busy graph here, but in this graph, we're comparing the responders to the non-responders. So respondents were in blue, and their characteristics you can see is the length of the column, length of the bar, and then the non-respondents are in the light blue. And so ultimately, we would really want to see that the respondents match the non-respondents. That would be that would imply that there's no bias there. But what we see is that income distribution, the non-respondents were much more likely to be in this tertile 1 group. In terms of race, they were more likely to be non-white. Again, ethnicity, we got that pretty well matched. Education, the non-responders were, or I would frame it the other way, the respondents were much more educated than the non-responders. And then we also have some metrics of overall health status, which was really interesting to look at. And in general, the non-responders were of poorer health than the responders. And again, this is really all attributed to the to the way we went about collecting these data, because we were selecting only those folks. We only reached out to those folks through web URLs, through phone. We didn't do the in-person, and that's what I want to stress here, is that in-person surveying is really the way that you're able to capture some of these harder to reach, more vulnerable populations. And I think that's the biggest driving take-home message for this session, is that to quantify who's responding to these surveys, who responds to web surveys. And we know that it's a more wealthy population. they have better health. And so when you think through, not only for COVID surveys moving forward, but your primary data collection, think through how exactly that's going to impact your results. I think that's a really critical consideration there. So with that, I know we're right at 1 o'clock, a little bit late. So I'm hoping for about 5 minutes of questions, but if that's not possible, that's fine as well. And not that I don't want to entertain questions, I do want to prop up our next session in this practice-based audience, which is a colleague of ours from the Institute as well. So good to see you too. So yeah, thanks everybody for your time and attention, and I encourage you again to stay with this group and hear what Elizabeth Thomas and her group has to say. Thanks everybody.
John.